Hi, my name is John Rees. I work as a consultant in rheumatology and sport and exercise medicine. I've been a consultant for about 12 years. So I'm interested in all general aspects of rheumatology and also all general aspects of sport and exercise medicine. In particular, I've got a big expertise working in rehabilitation, having worked at the Defence Medical Rehabilitation Centre, Headley Court, for 9 years as a consultant there. And also I've worked a lot in elite sport at all levels, Olympics, Paralympics, professional football, rugby, etc. But I'm probably most known for my work on tendons, which is what I did my medical doctorate on, and the work I've published in that area. I was going to more sort of general broad brush to say what causes injury, why do injuries happen, and if we know why they happen, can we think about how we could prevent them. I'll talk a little bit about exercise-induced pain and how thinking has changed in that, and talk a bit about barefoot running as well. Is it something that I should be doing? Is it something that my patients should be doing? Is this something we should be advocating, or is that asking for trouble? I'm trying to think of a definition for why we get injured, and the simplest one I can think of is when injury occurs when load exceeds tissue resilience, and that can be acute, i.e. trauma. That's essentially where loads exceeding the resilience of the tissue to absorb it, or chronic or anything else in between. Traditional medical thinking of, well, rest, drugs, if that doesn't work, you inject, if that doesn't work, you operate. It's kind of not appropriate for many running injuries, especially, a lot of sports injuries in fact, but especially running. And generally speaking, if you look hard enough, running injuries have an identifiable cause, okay? In terms of working out what that is, history is the most sensitive. Examination can help. The diagnostics can help as well. They can certainly help, in particular, I think, on severity. But really, the diagnostics are there to confirm your findings. So the traditional thinking was that your compartment is too small, and as you exercise, the muscle expands, and the pressure builds up, and that leads to pain, which you cannot run through. It is often bilateral, and it has a predictable onset. The pain is described as crescendo. It builds up and up and up and up until it forces you to stop. There may be a tingling or a paresthesia in the feet. There may be foot slapping. The gait changes, and a tightness, a burning like something about to burst. And it fades. It fades away after 30 to 60 minutes, and then you can carry on running again. Okay. And you may, the only sort of signs really, particularly immediately post or during exercise, you can see these muscle hernias, which does suggest that there's increased muscle pressure in here, tibialis anterior, the anterior compartment. How do you select the right patient for surgery? Well, apart from your history, examination, you would do an investigation, and there isn't space for radiology particularly, but you would do a pressure catheter, and if the reading was high, then that would be an indication for surgery in the right patients. So it's a pretty straightforward procedure to put a catheter in here. You're well away from the vascular bundle, and then ideally you want to get the patient doing as physiological an exercise as possible, i.e. put them on a treadmill, get them to run. You could do the same for posterior compartment. It's helpful to have ultrasound to ensure you don't go into the neurovascular bundle. Essentially, the principle is the same. And then if you have a positive study, you'll get right or left, very high, that sort of resting, and crescendo increasing pressures in your compartment. But despite standardising our surgeons, standardising the rehab trying to get the best possible patients together, the most accurately tight defined homogeneous group, and I think any surgeon will tell you one of the secrets of good surgery is good patient selection. Often the post-op results were quite poor, despite high intermuscular pressures. So why is that? I mean, there are a few reasons. It may be they just scar up again. And so the operation perhaps is technically successful, but for some other reason it just it just scars up and it doesn't effectively release the fascia. So given that surgery wasn't that successful, was there an alternative way of managing these patients? And if you start to look at the diagnosis, you realise that it's perhaps not as concrete as you might think. Certainly, if you overload tib band, that's going to fatigue more quickly than gastrocnemius. That's well known. And we saw a high incidence of excessive heel striking in these patients. So fatigue and overloading, that can cause pain. Well, we know that. Barefoot running is not new. Well, some of us remember Zola Budd, some are older ones. The famous race with Mary Decker. What did change in the 70s, we had the sort of inception of the modern running shoes with your midfoot support, your anti-pronation, your big heel, and go faster stripes, whatever really. But effectively what this does is this turns us into a nation or a world where it promotes excessive heel strike and then forefoot off. Apparently, they can correct for high arch, flat foot as well, but obviously has been criticised. And is there another way? But does it actually work? And if the arguments are from Lieberman and McDougall, so we've been running for hundreds of thousands of years. The modern shoe's only been around a while. There's an epidemic of running injuries. Some people would have you believe that that's perhaps the cause. But certainly there might not necessarily be much evidence that the modern shoe reduces injury. Lieberman's work, if you look at pressure, essentially it doesn't really show a reduced force, but it shows a slower rate of force loading and without a peak from your heel strike, and so it's smoother, and the argument is that this will lead to less pressure, less force leads to less injury. Barefoot running promotes forefoot or midfoot impact, shorter stride length, higher cadence, that's the other thing that was in our program, and a more forward leaning centre of gravity. So reduce forces, certainly yes to a degree. Reduce injury rates, certainly it may promote a better style of running, and I think excessive heel strike is bad. I think that's a reasonable tenet to take from it. But perhaps you've got responders and non-responders. The responders don't come to your clinics because they don't need to, and we see the non-responders. So my view on barefoot running is it promotes a more economical gait. That's good if we transition slowly. It'll suit some more than others, but it's a skill. It requires a careful transition. But I think you can think of it, and it does make sense when we think of forces, distribution of forces in terms of injury and injury occurrence.